Hello, everyone, and welcome to today's webinar titled Dengue, Imagine Challenges and Future Directions. My name is Dr. Obiageli Okafor, and I'll be your moderator for today's event. Today's educational webinar is presented by LabRoots and brought to you by Thermo Fisher Scientific. We encourage everyone attending to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentations. And also, if you experience any technical difficulties, you can also utilize the Q&A box and we'll assist you directly. So now, I'd like to welcome our speaker, Professor Neelika Malavige. She's a professor at the Department of Immunology and Molecular Medicine at Sri Jayewardenepura University and a member of the Executive Committee at the International Society of Infectious Diseases. Professor Malavige is also a visiting academic at the MRC Weatherall Institute of Molecular Medicine, the University of Oxford. And so thank you so much, Professor Malavige, for joining us today, and I'll hand over to you.
Thank you, Obi. It's an absolute pleasure to be doing this webinar and talking about something that is very important today and becoming more important and is very close to my heart. So to start off, the reason why we are having this webinar today is because what is happening with dengue in the world today. So for instance, if we take the number of cases of dengue from 2009 to 2019, which is a 20-year period, there was a tenfold rise from 500,000 cases in 2009 to 5 million in 2019. But from 2019 until for 2024, which we are today, so far we've had 12.4 million cases of dengue. That's just a massive, enormous rise of cases. And of course, it's not just the cases that are rising, as you see on your right-hand side graph, where the deaths are also increasing. And it is the only infectious disease where the annual case fatality rates are rising. So that is something, again, very important. So today what I'm going to talk to you about is the impact of climate change, why we are actually seeing this massive surge of dengue, the risk factors for increased mortality rates, because I just said that dengue is the only infectious disease where we see annual case fatality rates increasing, the healthcare challenges due to increasing cases and challenges in diagnostics, challenges in dengue management, and briefly touch on vaccines and treatment. Now, coming to the important question of why is dengue rising globally, climate change and what it does to the vector is important. The virus is also evolving, and there is a spread of 4 serotypes globally. Then there are also factors like rapid and unplanned urbanization, population factors like fragile health systems, political and financial instability, which we are currently seeing globally, and humanitarian crisis and large-scale population movement, which are all contributing to this increased surge in dengue. Now, I think everybody does know that climate change is happening, and what climate change does is it makes the world a warmer place. So in 2019, the figure on your left is the mosquito habitat in 2019, which is the spread of Aedes. So it's the Aedes mosquitoes that transmit the dengue virus. Aedes aegypti is an urban mosquito, which is mainly responsible for transmitting dengue. You have Aedes albopictus as well, which is less competent than Aedes aegypti, but is one of the main mosquitoes, again, transmitting dengue. So you can see from 2019, as we transition into 2050, because of the rise in temperatures, the Aedes mosquitoes geographical, there is expansion of these mosquitoes. So in summer months in Europe, US, where you've never previously seen dengue, these countries will also be experiencing dengue, and also higher number of cases in dengue endemic countries in the tropics and subtropics. Now, uh, how does this rise in temperature affect dengue transmission in mosquitoes? So the increase in temperature stimulates egg hatching and accelerates growth of larvae. So for instance, when the temperature is 15 degrees, it takes 39.7 days for the hatching of the egg for the larva to mature into a mosquito. But at 35 degrees, the development of egg to a fully matured mosquito takes 7.2 days. So there's a rapid turnaround of mosquitoes with the rising temperature. And also the mosquito gonotropic cycle shortens, and also at higher temperatures, the mosquitoes bite more frequently. And there's also an increased viral replication within the mosquitoes at higher temperatures. So all these factors contribute to increase in spread of dengue with the rising temperatures. Now, again, something that has happened over years is dengue was, of course, first reported in the 1940s and 1950s, especially in Southeast Asia. That's when the first sporadic outbreaks were reported. And even in the 1980s, many countries just reported circulation of one dengue viral serotype. So there are 4 dengue viruses which are very closely related that transmit dengue. And during the 1970s, 80s, there was only one serotype circulating in one country. And this got a little bit worse in the 1990s, but in where we are now, we have multiple circulation of all 4 serotypes in all tropical and subtropical countries in the world. So this is again, so people are exposed to these multiple dengue viral serotypes and are infected with dengue viruses many times in their life. And another thing that has happened over time, if you look at your figure on the right, initially dengue was a pediatric illness. So most of the dengue cases were seen in children. And the right-hand figure shows you what has happened in Thailand. So over years, from 1981 to 2017, you can see more and more dengue hemorrhagic fever cases happening in old individuals. Now, of course, the population in the world has aged, so that there's an aging population. But the top right figure shows that the increase in dengue hemorrhagic fever cases in the old individuals is not proportionate to the increase in the age of the population. And the top left figure is from Brazil, again showing a rise in cases in the young adults, especially 20 to 40 years, which are not the pediatric age group. And in the bottom left figure, again, that's data from Sri Lanka, where I come from, showing increase in cases in children. So for instance, in before year 2000, 60% of cases were in children, that is individuals less than 19 years of age. But in 2023, only 25% of cases were in children, whereas 75% of cases were in adults. Now, when you have cases in adults, this has issues, which I'll come to. But if you look at these global patterns of trends in the incidence and mortality, you can see the incidence has increased in all age groups, males and females, from the 1990s to 1990 to 2019. In all age groups, dengue has increased, but if you look at the mortality rates, which is the lower half of this table, you can see the mortality rates have actually reduced in children. For 0 to 9 group, the mortality rates have reduced in both male and female children between the ages of 0 to 9, whereas the greatest increase is in old individuals, especially individuals over 70 years of age, and we did not see dengue in very old individuals earlier. And when you have more infections in old individuals, in adults, there is more infection in pregnant women, infection in elderly individuals, and infection in those with comorbidities. So what this causes is, large systematic analysis, meta-analysis have shown that comorbidities like diabetes, hypertension, renal disease, and cardiovascular disease increase the risk of severe dengue. And historically, of course, secondary dengue infections, which is when you have dengue the second time or any subsequent time, you're more likely to have severe disease. But the risk of severe disease with these comorbidities is far higher than the risk with secondary dengue. So, and this is a huge problem globally, where we see an increase in cases in adults who have comorbidities, which of course leads to more cases of severe dengue. Now, again, coming to case fatality rates, there's a wide variation in case fatality rates and in different regions. So if you can look at the table on your right, it shows case fatality rates in Latin America. You see a very wide range from 0.05 to zero point 0.4, something around 0.1. In Asia, the case fatality rates for some reason are higher than in Latin America. And in countries like Indonesia, this is reported 0.2%. In countries like Mali and Burkina Faso in Africa, it's around 0.55 or 0.3%. But interestingly, if you look at your figure on your left, you see the incidence and case fatality rates in different countries like Bangladesh, Brazil, Mexico, and so on. And in Brazil, of course, with the increase in incidence, you do see an increase in case fatality rates. But there are several outliers here. So for instance, Bangladesh, case fatality rates are pretty high compared to other countries, followed by Philippines. So for some reason, when you look at the incidence of severe dengue and the case fatality rates appear to be higher in some countries in Asia than in Latin America. There could be multiple factors for it, of course. Now coming to, okay, who dies of dengue? Your left-hand graph shows how the incidence of dengue has increased in Brazil over the years. And of course, the deaths have also increased over the years, especially in 2024, where there was a massive, this year, there was the worst outbreak in history. And your right-hand figure shows you the deaths. And you can see that the deaths are actually in the old age groups, especially in people over 8 years or over 60 years of age. But if you look at the distribution of deaths in the young age groups or the young adults, in the 20 to 49 year age group, the deaths were higher among females, which is 34 versus 20 in males, but above 50 years of age, the deaths were more frequent among males. So it's not just in Brazil you're seeing this data. This is data from Bangladesh, and Bangladesh had it pretty bad this year and last year, with case fatality rates early this year was around 1.1%. It has fallen towards the end of the year. You can see in your left-hand figure, the hospital admissions are actually higher among males, especially males in the young adult age group. Your figure on your right shows the death rate, and you can see the deaths are higher among females in the reproductive age. And in another large meta-analysis done by Ilaria's group showed that females do have a higher risk of severe dengue than males, especially when you take away the children. And there are many reasons. One reason is, of course, pregnancy. So a pregnancy in dengue is pretty dangerous. So dengue increases the maternal death 3 times. And if a pregnant woman has dengue hemorrhagic fever, that increases the maternal death by 450 times. That's pretty high compared to non-pregnant females. And pregnant women are more likely to require ICU admission, ventilatory support, and multi-organ failure, and also fetal complications like stillbirth, low birth weight, and preterm delivery. So dengue in pregnancy poses a huge complication to the mother and the unborn baby. But apart from pregnancy, women are also seen to be at risk of increased case fatal rates because of multiple reasons. Now, of course, coming to comorbidities and dengue, I showed you a slide earlier that a meta-analysis showing that comorbidities increase the risk of severe dengue. I mean, so many studies have done, numerous studies done showing diabetes, cardiovascular disease, asthma causing increased severe dengue and mortality, and possible reasons why this is happening. And so we did a study in Sri Lanka, not just looking at if dengue in hospitalized patients increase severe dengue, but the question we wanted to ask is whether obesity increases the risk of hospitalization. So this is a study which we did in 9 districts in Sri Lanka among children, where we looked at the dengue serostatus and also collected information of whether they'd been hospitalized for dengue. And what we found was so we looked at the BMI centiles, because you can't look at the BMI in kids. And kids who had a BMI centile of more than 90, they were in the 97th centile or above, had a significantly higher risk of hospitalization due to dengue than non-obese children. So all these comorbidities not only increases the risk of severe dengue, they appear to increase the risk of symptomatic dengue requiring hospitalization. And with the increase in obesity, diabetes, and all these other comorbidities globally in the tropics, subtropics, and everywhere, so this is likely to contribute to dengue getting worse and dengue becoming more severe. Now, again, why do patients die of dengue? So I was showing you data, the risk factors of severe dengue and who dies of dengue. But coming to why do patients die due to dengue? So right now, a lot of people think that, okay, dengue is not a very severe disease, it's a mild disease. Most people who are infected with dengue have no issues. So why should we actually worry about dengue? But if you look at historical data, so on your right is a figure from Indonesia over a period of 50 years. And you can see when Indonesia initially started experiencing dengue, the case fatality rates were over 60%. I mean, that's pretty high. Over the years, of course, the case fatality rates have declined. And if you look at Thailand, again, in the 1950s and 60s, the case fatality rates were over 10%. And if you look at many countries which initially experience dengue outbreaks when they're not used to dengue, the case fatality rates are pretty high. So with time, the reason that the case fatality rates reduce is not because dengue becomes less severe, but the clinicians and patients in those countries learn how to recognize signs of severe dengue or the dengue warning signs. So they present to hospital early for fluid replacement. And of those patients who are hospitalized, around 37% develop plasma leakage. So when plasma leakage is left untreated, so the treatment for plasma leakage right now, because there is no treatment for dengue, is fluid replacement. So if timely fluid replacement is not done, the mortality rates can be over 20%, which was what we saw in the 1960s, 70s in many Asian countries. Now, of course, then why don't we just identify patients with dengue, do fluid replacement? It can't be so difficult, right? But how do patients actually present with dengue? What are the clinical features? So patients present with typical clinical features such as fever, lethargy, muscle aches, joint aches, headaches. About 25% of kids also complain of sore throat. They can just have GIT symptoms. They can just have abdominal pain, vomiting, and diarrhea, which is like a stomach flu. And if you do their bloods, their full blood count and so on, they will have varying degrees of lymphopenia, lower platelet counts, elevated liver enzymes, and sometimes elevated C-reactive protein, not very high. And when you look at these clinical features and laboratory features, they mimic many febrile illnesses that we see in our countries, like chikungunya, influenza, now we have COVID, leptospirosis, Zika, acute gastroenteritis. I mean, so many. So it's when you have an outbreak of all these infections at the same time, which usually happens during rainy seasons, because it's in the rainy seasons you have COVID, influenza, leptospirosis, and so on, and other mosquito-borne viral infections. It is pretty difficult to pinpoint and diagnose dengue purely based on clinical features. And so there are diagnostic tests which either detect the virus or antibodies. So of course, in early illness, you have the virus, which you can detect by detecting the viral RNA, or you can detect, there are tests to detect one of the non-structural proteins of the virus, which is NS1. And so there are point of care tests and ELISAs to detect the uh, dengue NS1, which circulates independently of the virus. Later on in illness, you of course can detect dengue antibodies. So, but how good are these tests? So this is a study which evaluated 4 different types of point of care NS1 antigen test and ELISAs. And you can just see, like if you go through the sensitivity of these tests for the different dengue viruses, dengue 1, 2, 3, and 4, there's a huge variation. For dengue 1, they appear to be quite sensitive, sensitivity above 85%. But if you look at the sensitivity for dengue 4, the sensitivity is pretty low. And this is one of the issues. And in certain outbreaks, the NS1 antigen test sensitivity depends on the dengue serotype, and there's a poor sensitivity for dengue 4. And so just because a patient comes and you do happen to do a NS1 antigen test, a negative test doesn't exclude dengue. So we have issues with these point of care diagnostics. In many dengue-endemic countries, you do not, although they are point of care, they are not, because of the price and the affordability, they're not available in many public hospitals, which means that you will have to do a clinical diagnosis. And even if the test is negative, it doesn't necessarily rule out dengue. And also, as I mentioned, there are 4 dengue viral serotypes, and based on the kinetics of these viremia varies according to different serotypes, and also the immune status. So if somebody has the first dengue infection, or you call it a primary dengue infection, the duration of viremia is significantly longer than somebody who experiences a secondary dengue infection, or that's called any subsequent dengue infection after the first. You can see that the viremia rapidly declines in a secondary dengue infection. And the viremia is more prolonged in dengue 1 compared to dengue 4 or sometimes dengue 3. So there is a huge variation among dengue serotypes as well. And so this is why you have these differences in the dengue NS1 antigen test based on the serotype, because of these changes in the viremia. And also based on your immune status, because of course in secondary dengue, the viremia disappears faster, the sensitivity of these tests also differ. So in primary dengue, as you can see in the top graph and in the figure below, in primary dengue, the qPCR and NS1 are sensitivity is higher than in secondary dengue, because the viremia stays for longer, and also you have higher viral loads and higher NS1 levels, because there is no antibody to neutralize the virus and get rid of the virus. So in primary dengue, qPCR and NS1 antigen, which are viral detection assays, are more sensitive. But in secondary dengue infection, the antibody assays are more sensitive. And you have a very different antibody response in primary and secondary dengue. So for instance, as you can see in primary dengue, because that's the first time your body is seeing the virus, you have an IgM response followed by IgG response, which you would get for a typical viral infection. But in a secondary dengue infection, you have a IgG response, a really large, massive IgG response very early in illness, and that is not for the infecting dengue viral serotype, but for the IgG specific for the previous dengue viral serotype, which rapidly increases when you get infected with a different viral serotype. So you see a very early, massive increase in IgG, and sometimes you do have IgG later, but sometimes because the IgM response is very small, you might actually not detect it. So in secondary dengue, you might have IgM IgG response, or you might just have a IgG response with delayed or absent IgM response. And this is, and the other big complication is, of course, with this cross-reactivity between flaviviruses. So flaviviruses are they are very cross-reactive with each other. They're very similar to each other. So the antibodies that are generated against a flavivirus, the antibodies tend to cross-react. So dengue and Zika virus, the dengue viruses and Zika virus is quite similar. And you can see this is evaluation of 3 diagnostic tests in 122 Zika patients. So these 122 Zika patients, their serum were tested with ELISAs, dengue ELISAs. And in early illness, that is before 7 days, about 60 to 70% of patients who had a Zika infection gave a positive IgG response. But in serum samples collected after 14 days, all the assays gave a positive response, which is a 100% response for dengue antibodies in patients who actually had Zika infection. But the IgM is better. The IgM is less likely to cross-react and give a false positive response, but you can see it's still there. So this is cross-reactivity is one of the problems or limiting factors in detecting or confirming infections with a particular flavivirus. Okay, so now coming to clinical stages and what actually happens to a dengue patient when they present to hospital, and why it is important for us to know this. So as I mentioned, patients present with the typical symptoms of myalgia, arthralgia, headache, vomiting, nausea, fatigue in early illness, and quite a large number of patients, the vast majority, then recover and the ones even who go into hospital to observe them can go home. But in a proportion of patients, they develop plasma leakage. And when the plasma seeps out of the capillaries, of course, then the hematocrit or the PCV rises, and also the platelet counts start dropping. And this is called the critical phase, where you have the leakage happening and the platelet counts going down. And this is usually accompanied by abdominal pain, bleeding, and so on. And the patient actually, the fever might resolve, but the patient is still not feeling good. So it's very critical that patients are identified at this stage so that fluid replacement can be initiated. But why does this happen? And what is severe dengue? So severe dengue is characterized by a plasma leakage, which leads to pleural effusions, ascites, and shock, organ dysfunction, especially the liver, but you can get myocarditis and neurological manifestations, and severe bleeding. So you can have all 3 or just one of the 3 to characterize severe dengue. And what actually happens in severe dengue is there is plasma leakage. So the top right figure is our images from our lab showing endothelial cells with human serum, which the architecture being nicely preserved. The bottom figure is endothelial cells in the presence of patients with dengue serum. So you can see that the architecture is disrupted, the tight junctions disrupted, downregulated. And so what actually causes severe dengue and what leads to this cascade causing plasma leakage? So the dengue virus is detected by many pattern recognition receptors like RIG-I and NDA5 when the virus enters the cell. And if it's a secondary dengue infection, you have antibodies to the previous dengue infection, which can be uh, poorly neutralizing, but still bind to the virus. And then these immune complexes, antigen antibody complexes, are pulled inside the cell because these bind to the Fc gamma receptors, and you call it antibody dependent enhancement because now the antibodies actually enhance dengue infections of the cell. And once the virus gets in, many of the non-structural proteins interfere with the infrared signaling pathways and detection by pattern recognition receptors. And this leads to production of a lot of pro-inflammatory cytokines and inflammatory mediators instead of a infrared response. And also, dengue NS1, as I mentioned, circulates independently of the virus. And in vitro studies and mouse data have shown that it is directly involved in pathogenesis. So the NS1 can cause release of cytokines and inflammatory mediators from immune cells like monocytes and macrophages uh, uh, through TLR4. It also has shown to induce phospholipase enzymes and inducing production of MMP9 and also binds to HDL, stimulates cytokine production, and activates endothelial, leading to endothelial disruption and disruption of the glycocalyx. So NS1 has shown to directly contribute to disease pathogenesis and vascular leak. And the other thing that happens is there is a lot of immune activation. So the immune complexes also bind to these Fc gamma receptors in mast cells, causing mast cell degranulation, releasing histamine kinase tryptase, which cause endothelial dysfunction. VEGF also causing endothelial dysfunction. And apart from NS1, other cytokines, LPS also activates the phospholipase enzymes, generating platelet activating factor, leukotrienes, prostaglandins, which again cause endothelial dysfunction, and also activation of the inflammasome and NLRP3 in immune cells, again resulting in release of cytokines like IL-1 beta, which causes endothelial dysfunction. So endothelial dysfunction can happen because of multiple mediators uh, uh, working together on the endothelium. Now, all this is happening, and of course, it is very important to detect it early because, in the absence of treatment, the only option is fluid replacement. Now, let's say somebody comes with a febrile illness, and in the absence of, so we discussed that the existing diagnostics have a poor sensitivity and a biomarker that can predict who will develop severe dengue does not exist. So in the absence of these things, we have to sort of monitor all patients, febrile patients presenting to hospitals, and if they have dengue warning signs, admit them to hospital. In hospital, we have to monitor them more intensively to see who develops plasma leakage, bleeding, or liver dysfunction, organ dysfunction, to then timely and adequate fluid replacement, which is personalized. It depends on how much a person leaks, administration of blood or colloids when necessary, and symptomatic treatment. Now, if you have one or two patients, this is possible, but in the absence of treatment and when you need to monitor large numbers of patients, it becomes impossible. So you're right. The picture here is from a hospital in Sri Lanka during one of the largest outbreaks we saw in 2017. So in the right picture, you can see the number of patients in the ward, and the number of doctors and nurses don't multiply with the number of patients, and it's almost impossible to monitor patients and give personalized fluid management. So in the absence of biomarkers, I mean, there's been a lot of work done on biomarkers, but there's been a very wide variation in the results generated in these studies. And this is because of the differences in the timing of sample collection, the defining of clinical disease severity, whether patients with mild, moderate illness were included, or severe disease only were included, whether the patients were outpatients, recruited hospitalized patients, whether they had comorbidities, age, and so on. So, but the meta-analysis and systemic analysis, what has shown is elevation of a CRP, AST, certain cytokines like IL-8, reduction in albumin, and so on, is associated with development of severe disease. But although different studies show different things, one of the markers that have come up in all the studies is AST. So AST seems to be a good marker, which is a marker. I mean, AST is released from so many cells, including the liver. Important liver marker seems to be associated with subsequent development of severe disease. And of course, there is no drug for treatment of dengue. This is why plasma, fluid replacement is only a treatment. So people have been looking at antivirals, but of course, antivirals need to be given very early, given the short viremia, and at least in the first 72 hours. And many patients do not present very early in illness. But they are likely to benefit in certain patients who have prolonged viremia, especially people who are going to get ill. And just because the viral loads disappear in the blood, they still can be in tissue. So antivirals are likely to benefit. And also drugs that target host mediators, because plasma leakage is due to increase in many different types of host mediators causing endothelial dysfunction. So there have been many trials for antivirals. Trials that have been completed are on chloroquine, baloperamine, selgospir, lovastatin, and ivermectin. Most of the trials have been done by OCRU Vietnam and some trials in Thailand. Pharma has also been doing trials, but the trials by J&J and Atea have been abandoned. And the one that is ongoing are two trials, one by antiviral by Novartis and one by monoclonal antibody by the Serum Institute. So those are the only antiviral trials that are happening globally. There have been many drug trials targeting host inflammatory mediators. Two trials on Montelukast completed, one in Pakistan and one in Thailand, showing some promise, but again, not definitive evidence. Ketotifen trial was completed in Duke and US. We are waiting results. There were two trials using a drug called rupatadine, which was done actually by us, me being the PI in those studies. Prednisolone was also investigated, and there are two trials ongoing again by OCRU Vietnam on anakinra and baricitinib. This is for treatment of patients with severe dengue. Now, I don't have time to elaborate on vaccines, but there's a lot of things happening in the vaccine space. There have been 3 vaccines that have been either registered or in phase 3 trials. The first vaccine that came up was the Dengvaxia, developed by Sanofi. That was the structural proteins, PRM, and envelope protein with a yellow fever backbone. But because it was found to be less effective in seronegative children with the probability of inducing more severe disease, it was only recommended for seropositive individuals. Then we have the TAC-003 developed by Takeda. This is on a dengue 2 backbone with the PRM and envelope proteins of the other dengue virus. It's a live attenuated vaccine. This has been registered by the European Medical Agency, pre-qualified by the WHO. FDA is awaiting evidence. Again, it is been recommended to be used in high transmission areas and doesn't have equal efficacy against all 4 serotypes, especially with reduced efficacy against dengue 3. And we have the vaccine developed by NIH, currently undergoing clinical trials, phase 3 clinical trials, which the studies are looking promising. But I won't go into all that data because it's a different topic itself, but a lot happening in the vaccine space. So to summarize, the number of dengue cases, disease severity, and mortality rates are on the rise. Climate change, rapid urbanization, and and all this is playing a huge role. But unfortunately, we do not have adequately sensitive diagnostics. We do not have biomarkers, and we do not have a treatment for dengue. So, and there's a lot to be done in this space, given what is currently happening. So I have like to thank everybody in my team in Sri Lanka, collaborators from the National Institute of Infectious Diseases, National Dengue Control Unit, and Oxford, and all my funding bodies. And this is my disclaimer from Thermo Fisher. And so thank you, and I would like to take any questions.
Thank you so much, Dr. Malavige. Really, really, for all the really good overview that you've presented in this topic. And so right now, I'd like to just remind our attendees that if you haven't already submitted questions, please do so now. You just need to click the Ask a Question box to submit your questions, and we will take as many as we can in the remaining time. And if we don't have time to take it now, we will take it later. And so the first question that has come in is regarding the case fatality rate. So we had you covered a lot around case fatality and incidence, but one of the things that people noticed was that the case fatality rate is not always directly proportional to the incidence of dengue. So we have countries that have, yes, increasing incidence of dengue, but not the case fatality rate not increasing as much as the incidence of dengue. And then we have the opposite in like Bangladesh and Philippines, where we have very, very high case fatality rate, almost at par with their increasing incidence. So the question is, why do you think that is? Why are we seeing that disparity in countries?
That's a very, very good question. So there are multiple factors. So first of all, it depends on how fast the cases increase. So if you see a very sudden increase, a massive increase in number of cases, I think everybody is now familiar with what happened during COVID times, where the number of cases overburdened the healthcare system. So when you have like too many cases, in the sense not that you are in control of such things, then it over then the capacity to handle patients, the healthcare systems can't handle so many patients. So when the healthcare systems are overwhelmed, you can't, of course, then the fatality rates will increase, because in the absence of treatment, as I mentioned, the only treatment available is monitoring all patients, which is taking their bloods 4 or 5 times a day, doing a continuous monitoring of, like regular monitoring of blood pressure, urine outputs, and clinical status. So when you have hundreds of patients and the same number of doctors and nurses, it becomes impossible. So then things happen, and you miss. So this is one of the causes of increased case fatality rates, depending on the how fast the cases increase, and so on. The other thing could be actually viral factors, which is something that we are looking into. So we are doing this study in Latin America and Asia through this NIH-funded A2CARES program, which is Asia American Centers for Arboviral Surveillance and so on, which we're trying to understand these differences in disease severity and case fatality rates. So it could be viral factors. We know that certain virus genotypes do tend to cause more severe disease than others. That could be one factor. The other could be host factors. It could be genetics, and it also could be the presence of comorbidities. And what we know is in certain countries, like especially South Asian countries, we have a massive increase in diseases such as diabetes and obesity. Just to give you statistics, alarming statistics, in Colombo, Sri Lanka, where I am, the prevalence of diabetes among adults in Colombo is 32%. So that's pretty high. I mean, so in some Latin American countries, you would not have that high diabetes. So, and we know that things like diabetes, obesity are risk factors for severe dengue. So there could be underlying comorbidities, the age of individuals who are infected, the viral factors, the overwhelming of healthcare systems. So all these factors, I mean, multiple factors coming together can decide whether, the case fatality rates in different countries.
Yeah, thank you. Thank you so much for that answer. I think that actually flows in very well to our next question regarding surveillance. You talked about health system readiness. And so the next question is, in the context of dengue control, is surveillance useful? What role does surveillance play in managing outbreaks and all the seasonal peaks that countries experience?
So the importance of surveillance cannot be underestimated. I mean, surveillance is terribly important. Surveillance of human cases and also surveillance of mosquitoes. So I'll first talk about humans, um, because I mean, countries like ours, you always have some number of dengue patients with dengue, but but when there are serotype changes, so let's say we have just one, let's say dengue one for some time, and suddenly you get a serotype shift, then you have a population who have not had infection with that serotype. So when you get a serotype shift suddenly, then you have a massive increase in the number of cases. But you have a small time period, like maybe like a month before, like a gradual serotype shift and increase in number of cases. So there is time to act, to try as much as possible to control the vector, to reduce transmission of dengue, and also prepare the hospitals and allocate resources accordingly, so that you anticipate outbreaks. So, and that also involves physician retraining, because sometimes, best fluid management regimes and so on, so that even if you have increases, the clinicians are ready and are aware to best manage patients. So that's about surveillance. So that is to be ready for outbreaks and also as an early warning system. Other thing is, of course, it is important to monitor the different viruses that are coming up, because because of certain mutations. Uh, I mean, there's a potential of certain viruses to become more virulent than others. So these things have to be monitored. And in Sri Lanka, we had this issue where we had two genotypes circulating of dengue 3, one which was detected by the molecular diagnostics we were using, but the other genotype was actually evading diagnostics. So we had been using modified CDC primers for the last 10 years, but suddenly, our PCR positivity started dropping in patients who I mean, they were having, classical dengue symptoms. The PCR positivity rate was like 50%, whereas it was all not over 90% earlier. So a sudden drop in PCR positivity rate in patients coming with dengue, I mean, that's a concern. Then you know that the virus has mutated and evading diagnostics. So this is why you need to look at that. The mosquito surveillance, of course, again, when you look at the mosquitoes and changes in serotypes in mosquitoes, you can predict outbreaks happening in humans, so that you can take remedial measures to try and control vectors before you get massive outbreaks in humans.
Thank you. Thank you so much. I think that actually fits into another question about serotyping. So, in your presentation, you talked about how different serotypes might show prolonged viremia. And so, this question is: are there other clinical implications or even public health implications of serotyping dengue virus? Is it very important to serotype? Because, like you said, some of the diagnostics that are available, IgG, IgM, NS1, they all don't. In fact, some molecular tests do not serotype, right? So, what is the importance of serotyping? Is it even important?
Yeah, so serotype is not important for individual patient management, because it doesn't matter whether you're infected with dengue 1, 2, 3, or 4. I mean, who cares? After all, the treatment is fluid replacement, right? I mean, it's basically it's symptomatic treatment. So, like you find out how much the patient leaks, and you give the fluid. And you also need to monitor when the patient stops leaking. So you stop the fluid and you don't overload the patient. So for patient management, it doesn't really matter what serotype you're infected with. But it is terribly important for public health measures to understand how the virus is evolving, whether there would be any problem with diagnostics, as we discussed, whether the sensitivity of the point of care diagnostics might change. And also, since we're having these vaccines coming up, and there have been, like some data showing that when the circulating virus changes quite a bit from the vaccine strain, the vaccine efficacy can drop. So it is important to monitor the circulating strains and to see first whether that can affect vaccine efficacy. And also with these other vector control programs like the World Vector Program, again, there's a potential that certain things can evolve. So it's always very important to not just serotype, but to sequence and do viral surveillance.
Thank you. Thank you so much. And then the last question we'll take for today is expanding beyond dengue. There's been pockets of Oropouche virus outbreaks in Latin America. So Oropouche is an arbovirus, like we all know. So the question is, are there similarities between the epidemiology, the transmission dynamics, and public health responses to dengue and Oropouche virus?
Yes, so unfortunately, we see these different viruses coming up. I think until we got the Zika outbreak in Latin America, I think it was in 2016 or something like that, people hadn't heard of Zika. I mean, it was detected in African countries a long time ago, but the world was not aware that a virus called Zika existed until it was causing massive outbreaks in Latin America and leading to microcephaly fetal malformations and so on. So now we have Oropouche virus, which again came out of nowhere. I mean, it was causing outbreaks earlier, but this year it suddenly, instead of causing very small sporadic outbreaks, we have this virus emerging and causing like quite significant outbreaks. So unfortunately, this is going to be the likely case scenario in future, which is not good news. Having different flaviviruses, vector-borne viruses emerge, and yes, the clinical features are quite a bit similar to dengue, and although I mean, not ex- I mean, a lot of these viruses, Zika, chikungunya, dengue, in the vast majority of patients, the clinical symptoms are the same. So just by clinical diagnosis, you would not be able to differentiate dengue and Oropouche virus in the vast majority. So this is why it would be important to diagnostics to understand, okay, what are the type of flaviviruses we are having, who is getting infected with what, and so on. So antibody test would not be ideal because of the cross-reactivity between potential cross-reactivity, especially in later stages of illness. So it would be molecular diagnostics that would be most helpful to distinguish between different filivirus infections.
Thank you. Thank you so much for taking time to answer these questions. So before we go, I'd like to thank you, Dr. Neelika, for an exceptional presentation. And also, I want to thank the audience for joining us today. The questions that we didn't have time for today that have been submitted will be addressed. And then you can also submit questions even after during the on-demand period, and all questions will be addressed by our speaker via the contact information that you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for a replay. We encourage you to share that email with your colleagues that might have missed today's live event. Until next time, we want to say thank you again and goodbye.